So this morning I'm interviewing Megan O'Grady, who is a social psychologist and a professor in the Department of Public Health Sciences. It's been here 4 years, and looking forward to an interesting conversation with her. Good morning, Megan.
Good morning, Doug.
Thank you for doing this.
Absolutely.
I'm hoping we can have a conversation in which you tell us a little bit about your life and career path and how it led you to where you are now, and maybe that will inform or illuminate uh, the thinking for someone else coming up on a similar path.
Okay.
So let's start wherever you want to begin.
So I would say I have always been really interested in behavior generally, and I started early in my college career actually in animal behavior. And I took my first psychology class and thought, wow, this is actually the kind of behavior I'm more interested in. And throughout sort of my, early academic career, it became obvious to me that I was really interested in why people do things that aren't good for them, or end up in situations that are less than ideal. And I really focused as I moved through my career on social psychology because became very clear that the social environment and what's happening around people is just as important as what's happening inside people's heads. And so that sort of led me to my PhD program in social psychology. But also, I was very interested in the application and applied work, meaning I wanted to be out actually helping people and not sitting all the time behind a desk writing a paper and publishing, which is very important in academia, but really thinking about how do we apply theory and how do we apply research to actually get out in communities and in healthcare settings and that sort of thing, and really apply psychology to public health.
So, it strikes me listening to you that we live in a society where a lot of the onus or blame is put on the individual. Oh, it's your fault. You did this. Why did you do that? But you're arguing that it's important to look at the context of why people make the choices or decisions, or even if they're not choices and decisions, why they end up doing something. Am I right
Absolutely.
about that?
Yes, yes, absolutely. Yes, the context in which we grow up, we learn, we live, and the social relationships that we have, are that's been sort of the focus, and it's expanded sort of slowly out from social relationships all the way out into communities and larger environments, the healthcare system itself, and so yes, those are very important things that I focus on.
And your particular interest has been addiction. I think
Mhm.
that's the correct term. Uh, so, what have you learned about why people become addicted to substances? And let's start with that.
Well, I will say that my very first job, I was very, eager to get out into the workforce after my undergraduate degree, and so I took some time off to work. And my very first job was working in a behavioral health organization that was specifically for individuals coming out of incarceration or who were in the criminal justice system in some way. And so that early position, in which I was a caseworker. And then my next position after that, I was a group home manager in a behavioral health organization for women who had a lot of substance use and mental health issues. So all of those things really, showed me again that it was important to really understand what's happening in people's lives and why people end up in different situations. And so really the early part of my career and after my graduate school, I came here to UConn to work with Dr. Howard Tenen as a postdoctoral fellow. We really focused on really why young people use alcohol or drink, and sort of maybe drink to excess. And so those social norms that are happening around folks, but also things like social support that people have really impact people in very different ways, though. And so we were very focused in my early work when I was here as a postdoc on, um, what's happening day to day. So we were collecting data and having people, sort of answer questions every single day and then look
Mhm.
at how much they drank that day. And so, there's no easy answer to what's happening, but I think we were able to pinpoint some different things about, sort of normative behavior, what's happening around a college student that they may drink to excess. So were they embarrassed the day before and they were sort of managing an emotional reaction, for example. So that was the early work, but as I've sort of gone into more of the health services area, my work has focused much more on how do we make the treatment system better? So it's less focused on why do people, sort of do the things they do, and more we sort of know that there are some severe problems out there. We have the opioid epidemic, alcohol use is really at an all-time high. And how do we actually provide better care to people who are now, in a system that doesn't serve them well?
So some of the addiction is physiological,
Mhm,
and some of it I think might be more psychological.
mhm.
Is there a difference in the treatment, or is there a nuance to the treatment depending on how much it's one or the other, or do we even know how much it's one or the other?
I would say that, if we're thinking about how we diagnose somebody with a substance use disorder, both physical dependence is important, but also the behavior of using substances. Is it disrupting somebody's life? Is it, that they're craving using that substance so much that it interferes with their ability to do anything else? And so there are different and the thing that complicates that is it's different by substance. The substances affect the brain differently. And so for some substances like opioids, we have really great gold standard medications that can really change people's lives. But things like stimulants, like methamphetamines, there aren't good medications
Mm.
necessarily, although, there's always new things coming out. But we know a lot less about how to treat the physiological and sort of brain piece of this. And we focus more on behavioral treatments. But I'll say behavioral treatments work fairly well, like cognitive behavioral therapy and some of the common things that are used across different substances. But one of the big focuses of, my work now is how do we actually get these evidence-based treatments, whether it be a behavioral treatment or a medication, to people, who are trying to access these services. And it's, very, if you look at the data, it's just not good, and the kinds of treatments people are able to access, even if they are going to treatment, sometimes they aren't offered the right medications or at the right doses, for example.
My sense is there's not, and I'm not an expert in this, obviously, but my sense is the availability of treatment is not sufficient to the need. Is that correct?
Yeah, the availability is not, and particularly if you look at a rural area, sometimes
Okay.
people are traveling, if they want to access methadone treatment for their opioid use disorder, which is the gold standard, one of the gold standard treatments. The way that the system is set up is there are so many regulations around how people can access that medication and they often have to go to a clinic every single day. And if you live an hour away from that clinic because you live in a rural area and there's only one clinic that does that, then you're, in a really bad situation where you're either not going to receive that medication or, you're just not going to be able to maintain that. If you want to have a job or anything else happening in your life, but you're spending 2 hours, 1 hour each way driving to a clinic, that's not good. And so in urban areas, things are a little bit different, but there are other problems that sort of get in the way of people accessing treatment. So certainly, the need is out there and treatment isn't always available. It varies by state even because there are different policies, different sort of ideas about what the most important treatments are, which is unfortunate. But yeah, so that's a problem. But then even if people are able to access treatment, sometimes they just don't receive the best treatment. Substance use disorder treatment has really started with um, an abstinence-based focus,
Hmm.
meaning people had to completely stop using substances. And we know that that doesn't really work that well. And there are still a lot of ingrained thoughts about that, that a lot of the work that I do is trying to change, how clinics and people who work within them think about, these and, the norms are slowly changing around that, thankfully.
Some substances are legal in some places and others are not.
Mhm.
I think that must be a factor in treatment as well, because someone who's using an illegal substance is probably inclined to be more secretive or hesitant to reveal. Am I correct about that?
I don't know if it's so much about revealing as much as, if we think about something like cannabis, that
Yeah.
has become legal in many places now. It's not federally legal, though we see, that may be changing. But I think, one of the things that comes up a lot in the work I do is somebody might be coming in for treatment for their opioid use disorder, but they're also using cannabis and drinking. And in the old days, that treatment program would say, you know what, if you keep doing all those other things, even if you stop using the heroin, for example, you still can't be in this program because you're still using. And I think, slowly those ideas are changing where people are more likely to disclose that, hey, I did stop using heroin, but I'm still smoking weed, a couple times a week. And if that's not interfering with somebody's life and their ability to sort of meet the goals that they have for themselves, then that's slowly becoming, a thing where people are okay with that in treatment programs. But it's changed a lot, even in the last few years, as things like cannabis laws have been changing, where I think people are more likely to disclose, that they're using that. It's an important thing for people to understand, both if they're going to their regular primary care doctor as well as if they're receiving treatment, so that we can make sure that there's no other medical sort of interactions or other things that people might need support with. So, yes, definitely sort of the changing legal, sort of landscape is challenging, I think, as people are trying to figure out what the right, you know, thing to do is for somebody in treatment and where treatment programs try to draw the line.
If you were talking to someone who was earlier in their career and interested in this
Mhm.
issue, what advice would you give them? I mean, it seems like a very important issue, but also quite daunting
It is.
to
It is.
take on, right?
And it is, and I would say there's no one path to doing the kind of work that I do. I started in a very traditional kind of psychology background and slowly sort of worked my way into public health and health services research. And that's where I really found my home and really thinking about how do we implement things. And so, but I work with people with health economy backgrounds, with public health, more traditional public health or epi backgrounds, people who are physicians. And so it's a really team-based culture and requires a lot of different background sociologists, everybody, can come together to think about this. So I would say there's no one wrong pathway. And, often I think people trying to get into this work think that they have to become a clinical psychologist.
Hmm.
And you don't. You can do this kind of work even in clinical settings with any kind of, sort of social behavioral background or medical background. So, I think that's the exciting thing, though daunting. It's exciting to be able to work with teams and really think about problems in a team-based way. And things seem a little bit more um it feels like you can solve problems in a way that may not be possible if we think about like one person working on these very big issues.
And one of the things that, I think you know this about me that I feel is that in public health, as public health academics, we shouldn't just be publishing. We should be
Hmm.
trying to have an impact in the real world. And it
Right.
strikes me that you agree with that and that that's what you're trying to do. And you were sort of academic adjacent before you came
Hmm.
here, and now you're a professor in the academy. How do you feel about that effort to transcend the academic boundary
Hmm.
and engage the real world and have an impact? Publications have an impact, but having an impact on, for example, on substance abuse
Hmm.
programs in Hartford or wherever it is, or New York or whatever.
Yeah, I mean, I think that's always been an important part of how I think about doing the work that I do because, again, we can publish papers, very important. But if we don't have the ear of policymakers or practitioners or regulators, then, if we don't have them at the table from the beginning, then it's hard to sort of say, oh, here's what I found, now implement this. And so, really in the work that I'm doing in New York as well as now here in Connecticut, is to really work in partnership with state agency folks, with people who work within clinics or healthcare systems, and have them as partners. And they may not have research backgrounds, and we
Right.
complement, the kinds of information that we have, knowledge base we have, and sort of approach we take. And so, it's harder, it's slower kind of work, and it takes a lot more sort of trust and relationship
Yeah.
building. So that's, I think, sort of the downside is it's harder and longer to do the work, but I think the impact you can have, after the sort of, long-term relationship building, I think can be really, great. And that's sort of even tackling the kinds of problems that I tackle. I think that's what sort of keeps me going is if you see people actually using, what you created in a research study or in an evaluation project, that's really important to me.
Can you give an example of where some of your work has led to something concrete that you feel good about that maybe has improved a treatment program or
Mhm.
something like that?
Yeah, I think the thing that sort of is coming to mind right now, although there are many things. One of the things that when I was in New York, the state agency came to us and said we'd like to build a better tool to identify what level of care someone should enter if they want to enter substance use treatment. So there are inpatient programs, outpatient. There are programs for detox if you feel like you need, something more acute. And so there wasn't really a good algorithm to sort of figure out how do we, place people where would they do best. And so we worked together with the state agency in New York to create a level of care determination tool. Over several years, we conducted a lot of research on it along the way, and that tool was implemented by the state so that every clinic in the state, um, if they were receiving a certain kind of funding, had to use this tool. And so it was something, and it's still being used to this day. And I can't remember how many years, but now it's been a number of years, and
Mhm.
we continue to have the data on the back end to look at, how
Right.
successful it is too. And so it's sort of um, a system that feeds itself and that, we can understand how it's being used out there, but also we can look at the data to see how well this is working. And so, that was one thing, that it took a really long time and a lot of work to sort of get to where we were, but at the end of the day, it was actually implemented and used. The other example I'll give is a current study that I have going on now in partnership with folks in New York at NYU and Walt Cornell and the state agency there is the regulations around methadone have changed because of
Mm.
COVID. There's more leniency in how many doses people can actually take home with them, so they don't have to come to the clinic every day, which is these regulations have not changed in decades. It's a huge change that could potentially help a lot of people. But a lot of clinics are really hesitant because they're, not sure how this is going to work. They don't want people to go out and overdose or have problems if they're not seeing them frequently or if they
Yeah.
have a lot of medication. So we're working to do a study to support clinics in implementing these new regulations, creating a sort of toolkit and testing that in a randomized trial, so that at the end of the day we can provide that, to not only in New York but other places that are sort of grappling with this, which is a federal regulation. So that's something that's sort of exciting and new, that will sort of be coming out, in a couple of years.
Yeah, I mean, your experience reinforces mine. I do community
Mhm.
collaborations and we try and see real change in the real world. And I think what you're describing echoes my experience, which is these changes take a lot more work than you might think.
Mm.
You might imagine naively, oh, that'll be easy. We're going to fix that. But it takes years and lots of time and effort to make
Mhm.
it happen.
Yes.
So, um, anything else you want to add from your experience for, again, for someone who might be inspired by your trajectory and career and thinking about doing something similar?
The only thing I would add is, I've always, and maybe to my detriment, have jumped into a lot of different things. And
Right.
so, you know,
I'm like that all
and
the
so, but I think it's served me well in that,
Yeah.
I think it's important, particularly if you're doing work in a changing field that regulations can change at any point, clinical practice can change, is to really, not shy away from working with different people. And so I think that's part of, the good and bad of what I do is, it's a lot to sort of work across a lot of different teams on different projects, but I think, that's the kind of thing you have to do in the health services research and implementation science world. So,
Yeah, I always think about times I've come to your office and I've looked in, and you have your calendar on your computer, and it's actually more filled up than mine as chair of the department. And I think, to your credit, that's impressive that you can manage all that and deal with all those people and
Mhm.
projects and juggle them. Uh, but it's also, I think, goes back to your point about if you want to have real world impact, it's not just about crunching numbers and
Right.
publishing papers. It's a lot about relationships
Absolutely.
and the process. And
Mhm.
so, yeah.
Yeah.
Well, thank you. I enjoyed our conversation, and I hope you did too.
Yes, I did.
And
Thank you.
take care.
Thank you.